Hello, Sarah.
Hi, Daniel. Hi, Abe.
Hello.
So I've just logged on my Fraser and I'm just setting this up to record. I do have to go to the Providence laptop for another meeting and I will be back to join you shortly. I just wanted to make sure we got the recording started here. So thank you so much, Abe, for doing this. I really appreciate your time and your knowledge sharing.
Yeah, no problem.
Okay, I'm just going to step away and you guys can feel free to start when you're ready.
Let's give one more minute for Anchor to join as well. Well, it says Anchor's away. So just pinged him through chat. Okay, we'll just get started then, since this is being recorded, so we can always view the recording for the bits he's missed.
Okay.
All right, can you see my screen?
Yes, I can.
Has anyone gone over Confluence with you before, Daniel, or is this the first time you've seen it?
No, with B, we see a little bit about Confluence. Yeah.
Okay. I think it's mainly new for Sarah, so some of what I go over might be stuff B's already covered, but any other questions that may have popped up since your last session with B, feel free to interject at any point.
Okay.
So Confluence is similar to one of our SharePoints or team sites in that it is used to store documents. It is used by the CST project and the clinical informatics teams at each site.
Okay.
Confluence is essentially a series of pages that hold documents, but navigating to each of these can be a little confusing. The first word I was about to say was annoying because I find it very tricky to find what you're looking for immediately. At the very top, Confluence is split into different spaces. Right now, it's just showing me the stuff I've clicked on recently, but if you're looking for, say, the page that houses all of the design documents for a clinic you're working on, that is most often in, say, the ambulatory space. But some of them might be split into other spaces, such as specialty diagnostics. Whatever that clinic falls under, information you're looking at could be in a different space entirely. To find a different space, there's always a directory, and it does let you search by name. But there are well over 7 pages, different spaces.
Okay.
Because there are so many different pages that you have to keep track of on Confluence, I strongly, strongly recommend once you find an important page just to bookmark it. For example, on my screen, I have a bunch of things I just bookmarked that I tend to refer to constantly.
Okay.
Or for my assigned clinics for a certain cycle, I will bookmark the individual page for each clinic, just to save myself a lot of searching. I find that it's easier. It is possible to, instead of using the browser bookmarks, to favorite a page, just this save for later option. If you click on this and go to your profile, you will see all your saved pages. Both options work just fine. It's just purely up to personal preference. I just like the bookmarks because it's easy for me to open them all at once.
Okay.
We'll start off with some of my generic links. I can share out all of the stuff I typically have bookmarked in chat or in an email afterwards. Actually, I think I'll just add it to the meeting invite. That way everyone will get it. So this is the registration space. I keep this bookmarked because each space has a tree on the left with different pages, each of which houses its own set of documents. Design 1.0 was not used anymore for registration. Early on in the CST lifecycle, they essentially restarted their early design work. So we are now living in design 2.0. I like keeping this page bookmarked just because it gives me quick access to this design 2.0 list on the left, namely for things like enterprise workflows. Those validated workflows in progress, and these are going to be nice, clear visual diagrams for multiple different workflows.
Okay.
So these are all the enterprise workflows, meaning this is happy path, what we try to get every clinic to do. If there are exceptions to these enterprise workflows, if we need a non-enterprise or localized workflow, if it's registration based, that is something that we'll be creating in Visio as well. But instead of saving it here with the enterprise ones, they'll be saved on the individual clinic page that you're working on.
Okay.
But this should always be the first thing you check to see what is enterprise, how should they be doing it. It's a fantastic resource to look up different enterprise level workflows. Workflow summaries are just Word versions of these, but I find them much more difficult to read through. I am a big fan of just the visuals in the first few sections.
Sure.
Back to another page that I keep bookmarked. Still in Enterprise 2.0, but this is under Transitions of Care and Facility Transfers. Specifically, this document here, Episode of Care Guidelines Mapping. One question that we'll get asked a lot when we're doing design work for a brand new hospital is when are facility transfers allowed between Site A and Site B. So this file is maintained by BAs on Rosween's team, the CSC Reg team. And it tracks, in the first tab, what is the enterprise workflow for a certain encounter type at a certain facility going to another facility? Is it going to be a discharge and readmission, or are they allowed to use the facility transfer conversation to move it over directly?
Okay.
The rule for what determines whether or not something can be facility transferred depends on reporting, because inpatient ED visits, a lot of these are reported to the provincial and then federal government, to CIHI, NACRS. And it depends if they are reporting out that visit all under the same facility code. Or if it goes across two different reporting codes for facilities, they have to be split into two different visits.
Okay.
So a lot of time we talk about facility transfers as you can facility transfer as long as it's within the same campus of care. And the term campus of care, you'll be hard pressed to find a good definition of, but the best short definition is, are they reported out together as a single facility? There's a little more nuance to it than that, though, because two buildings, even in the same campus of care, some encounter types can be facility transferred, some encounter types cannot. So it's question one, are they in the same campus of care? And two, is their encounter type valid for a facility transfer? It's
Okay.
almost impossible to just tell at a glance what is on the same campus of care. It is not intuitive whatsoever. Two examples I always like to use is Children's and Women's and St. Paul's and Mount St. Joseph. Children's and Women's are physically touching. They're two buildings. They opened a new building recently, and they actually share their new building as well. So it physically looks like they are on the same campus of care, but they are entirely separate. If someone is going from, say, neonatal ICU, which is in BC Women's, to pediatric ICU over in Children's Hospital, it has to be a discharge and readmit. Even though they are literally connected by a hallway, the buildings look almost seamless. We consider them two completely separate facilities as far as registration goes.
Okay.
The opposite end of the spectrum is Mount St. Joseph's Hospital, which is on, what's it, 14th and Prince Edward, and St. Paul's Hospital, which is downtown. They are almost half a town apart, but they are considered the same campus. They are reported out using the same institution number. We are able to facility transfer inpatients from MSJ to St. Paul's and vice versa, despite them being a good 15-minute drive apart. So what I'm getting at is never try to guess based on physical layout. Always refer to this spreadsheet, because the discussions about what is on the considered same campus, if those rules ever get changed, how it varies by encounter type, all of that is entered here. So this first episode of care mapping enterprise means here's the enterprise rules, and the second one are exceptions.
Okay.
So let's do a good example. Let's say inpatient. So if your original encounter was an inpatient encounter, and you are going to, in this case, the exact same facility, so in your same building, to emergency, where if you were to make a new encounter, it would be an emergency encounter. What should you do? Inpatient, going to ED in the same building, keep your current encounter, just transfer it into ED.
Okay.
Inpatient, same building. If they pass away, discharge current encounter, make a new deceased encounter. Scrolling over past the line. So now we're moving out from same facility to same campus of care. Inpatient, going to, there's inpatient here again. Inpatient in the receiving campus, same encounter, transfers inpatient. I'll keep scrolling a little further. Different facility and then different campus. Where's inpatient here? There it is. Now, because it's a different facility, when meaning outside the same campus, you discharge, readmit.
Okay.
So the way you read this table is always, this is your original encounter in your first facility. And if you were to make a brand new encounter in the second facility, that's what these that's what these columns are sorted as. So for example, inpatient to ED, we're not going to change the encounter type to ED, because we're just going to transfer them as an inpatient into that location.
Okay.
The encounter type makes a big difference, because even in the same campus of care, inpatient to EDs, fine, just transfer it. But if you have, say, a residential visit, there you go, residential, same campus to emergency, you can't do it. It's a discharge readmit, not applicable. Oh, sorry, residential, had a wrong one highlighted. So it's never just location A to location B. That's only the first step. It's always the two locations and what encounter type are they on. So you always have to consider both. This first tab, all the enterprise rules. The exceptions are noted on the second tab. For example, St. Paul's to MSJ, Hope Center to Lionsgate, and St. Paul's to MSJ. There's a bunch of different rules. MSJ and St. Paul's appear here twice, for example, because I believe ED to ED transfers are not allowed anymore, but inpatient transfers are allowed. But the exceptions tab is much, much shorter, but you read it the exact same way. It's just these first two tabs are the ones you have to worry about. Very useful. We get asked about this all the time. I was just asked about this about 2 hours ago in another meeting. So it's very helpful to know for your design sessions. Usually
Okay.
doesn't matter for outpatient clinics because outpatients are almost really never facility transferred anywhere. But if you ever work on a sustainment question for an inpatient space, definitely useful info. Never expect anyone to memorize this. I only have a fraction of this memorized myself. It's really just more important that you know where the information is and you can find it when you need it.
Okay.
Yeah. And next up, what else I have bookmarked in here? Counter type definitions. If this one I did bookmark the document directly. This is a long document that just goes over every single counter type in CST Cerner with usage and different business rules for each. For example, alternate level of care, the official definition, how it's supposed to be used, the exceptions or what it does not apply to. It also mentions how long certain counter types can be. For example, day surgery shouldn't exceed 24 hours. And if it can be transitioned to another care level or encounter type. So example, ALC is a good one. ALC, if it's in the same facility, can be flipped or transitioned to inpatient or tertiary mental health. In the same campus of care, so not the same facility, but same campus, meaning a different building, just inpatient, it can no longer be converted to tertiary mental health. If it's going between different facilities, meaning a different campus of care, you can never transition it to a different care level during the transfer. So this is very useful, especially for clinics, because clinics can use a mix. Even outpatient clinics will use things like minor surgery in some cases. Here are the rules for all business rules for outpatient visit types, virtual health, phone consult, phone message, which people often get confused with phone consult, recurring encounters, which includes the criteria for what the appointment criteria has to match in order for them to qualify for a recurring encounter type. Because if they do not meet the list of requirements in here, then they'll have to put in an EDD to make an exception for them using recurring encounters. That happens quite a bit. And the recurring section is, I think, full 2 pages, much more so than any other definition on here. It also links to another document, which is by itself, I think, another 20 pages, which I might as well talk about now. Recurring encounter type impact document. I think I bookmarked this separately because at the time this link was broken. But this is, oh, sorry, only 10 pages, but impacts of a clinic using a recurring encounter type, because at its core, Cerner or CST Cerner is really designed at a fundamental level for a single visit to use a single encounter. So using a recurring encounter creates a lot of complications for different downstream systems, even within the system itself, that have to be accounted for. This document lists all of those details. This is also the reason why we are usually hesitant to let new clinics use recurring, because it creates more work for everyone. Even if they meet all the criteria, there's still additional work that has to happen to make sure things work smoothly, because it's counter to how CST Cerner expects things to run.
Okay.
I think this one is, nope, that is in the wrong folder. This one is, sometimes we're asked to update this for data quality. Data quality has a number of email templates that they use to notify different downstream systems that they are making a change in Cerner. And those updates should reflect in their downstream systems automatically, but that's not always the case because of how interfaces work. Sometimes different message types get filtered out, or some things require manual remediation on the receiving clinic system's end. So we do update those email templates for them. We do update the addressee list. But outside of data quality, this list is also used by other people to note who could be impacted by certain changes. So we also constantly edit this page for new contacts for downstream systems as each site goes live. So I think the most recent edit we made here was for Forensic Hospital. And Forensic Hospital has a brand new downstream system called Flash. So all of these people had to get added to the contact list. And we also just have a general list of HIM supervisors or managers who typically run the records and registration departments in each hospital who often need to get notified.
Okay.
Has B or someone else talked to you about interfaces in general yet?
No, sorry.
Oh, no, that's fine. I think I booked a full hour. I can go on a short tangent then about how interfaces work. Let me actually switch to the interfaces space. I think they had a very nice diagram. Can we enhance larger? There we go. So in the center is CST Cerner. Each other
Okay.
circle is a downstream system that receives information from CST Cerner.
Okay.
So CST is connected to, I think the number now is about 51 or 52 downstream systems.
Okay.
That means any registration information that we add to CST will get pushed out automatically via an interface message to all these other systems. That's why a lot of the things we instruct clerks to do or design workflows are not always the easiest workflow for a clinic to follow. And sometimes they'll try to make shortcuts that to the clinic seem perfectly fine. But the reason why our workflows are structured the way they are is that we are trying to meet the needs of all the other downstream systems. So even though we're telling clerks in a particular clinic to do something a certain way that's a little slower than they think it needs to be, that extra steps or extra complexity is really added in to meet the requirements of a downstream system who's receiving info about their appointments or about their encounters. So that downstream contact list is the relevant contacts that have to be notified about any major updates, things like encounter moves or record merges in our original registration system.
Okay.
There are a lot, but the main downstreams that really have to worry about are the EMPI, because the EMPI does receive registration info from everything that we do. The lab uses their own system called SunQuest, and many patients get lab work. And there's Care Connect, which is really just used as a repository across all health authorities of registration and clinical data. And Finet has their own system called HRCM. So typically whenever there's some sort of workflow you have to make that's non-enterprise, if someone's proposing something odd, you just have to make sure you are considering how does this impact coding? How does this impact other downstream systems like the lab? How does this impact what data we're sending up to the API?
Okay.
We generally are not responsible for these downstream systems. As RCQBAs, we're really only worried about Cerner and the messages coming out of Cerner. What these downstream systems do with that message is kind of up to their own IT departments or their own BAs to manage. But no message comes directly from Cerner to a downstream system. There's always a translation in the middle, what they call the interface broker, that applies a lot of business rules and edits. For example, if CST Cerner has 2 address lines, but a downstream system only has 1 address line, that interface broker will concatenate both lines onto one before it lands in the receiving system.
Yeah.
So there. Oh, sorry.
Oh, it's okay. Yeah. Oh, it's okay. I understand normally the process, like how that's, yeah, the developer or programming they call service. Yeah, I know.
Yep. Yeah. So
It's
there's never
okay.
it's never a direct transfer of info. There's always a
No.
check and some
Yeah.
sort of translation happening. And that is also managed by the interface team, A lot of the work is just making sure that these interfaces, all those business rules and translation rules, are working correctly and are updated as needed. It also means that because they have a translation service in the middle, they can also filter out certain message types. For example, there's a different message type associated to a pre-registration versus a in-house registration. So some downstream systems ignore all the pre-registration messages. So if you're ever working on an issue with the downstream system, it's just important to understand how it works at a broad level. But really, we're just concerned that is the outbound message from Cerner containing everything they need? But sometimes you might work on things where the problem is that they may not be receiving every message, or they might be ignoring parts of a message. I can also send you a reference list of what those different message types are. So the format for those messages is called Health Level 7 or HL7. Sometimes in Jira tickets, you're going to see people talk about AO4 messages or AO8 messages. They're just different message types triggered by different reg actions. This is a very useful reference because if you click on it, it gives you a pretty decent description. So I'll send this out in the links as well. But back to Confluence. Next up is related to Jira. If you ever have to create a brand new report in CST Cerner, that's done through a Jira ticket, but the reporting team, I believe I'm in the reporting space, has a very nicely documented workflow of what they need you to do. They provide a template of what they want your first Jira ticket to look like. They include a template of their business spec document that they want you to fill out with the report details. Everything you need to know if you ever have to make a brand new report is found on this page. I've had to make a few over the years, but this page is great. Their process has changed, I think, at least twice that I'm aware of. So always double check this just to make sure you are following the right steps.
Okay.
Next Confluence page I use quite often is shared test accounts. I do most of my testing and poking around in the build domain, just because more things work in build than they do in training. So example, if you're using the training environment, things like the EMPI simply don't work. It'll always time out or give you no response. So any brand new patient you create in the training environment never gets a PHN, which means you're also seeing warning messages constantly about your patient does not have a PHN. Are you sure you want to continue? For testing purposes, most testing is done in the build domain. Whenever we're doing demos during design sessions, we always do our demos in build, just because more things work as closer to production in build than they do anywhere else. Build also lets you create patients in advance because build is never reset. So you can create a test patient on Monday in a prep for your presentation on Tuesday. This is a list of generic test accounts that you can use when you log into a build domain, and they're sorted by position. 9 times out of 10, I'm just simply logging in as test.superclerk, because that it has pretty much all the clerical access you could ever want.
Okay.
There's also test.dq for data quality. Otherwise, I would sometimes log in under a different position if I needed to check what does a scheduling clerk at, say, PHC have access to. What type of conversations does a radiologist have access to, for example? When we're doing demos for design sessions, especially for clinics, a lot of the workflow is driven by orders, where there's orders to scheduling or accept orders that also generate scheduling requests. You can log in using a test provider account to place those orders for your demos as well. It's not something that we're responsible for really teaching out during those design sessions, but if you want to show a full end-to-end workflow, this lets you place those orders on an account that does have access to it. So what I often do is have, say, schedule an appointment book open while logged in as a super clerk, and I also have PowerChart open while logged in as a provider, just so I can do the order entry piece on the side.
Okay.
And last thing I have linked, which I actually haven't looked at very long, is a list. These are recordings of different workflow demos. These are, I think, mainly scheduling focused. But when I was new to scheduling, I found this very helpful. I don't think they've really updated this very often, but also useful just because scheduling tends to be the most complicated part of RegSchedule. Because encounters tend to be very straightforward. Scheduling, especially remediating scheduling mistakes, is the most complex part in my experience.
Okay.
Yeah. Every Confluence page, because these are basically just web pages, you can always hit edit if you need to add something or remove something to the page, because there are some pages that we are responsible for making tweaks to. That list of downstream systems, if we need to make edits to it, we just click on the button, edit directly. And it's very straightforward. It's like a what you see is what you get editor. You just go in, type. You can use bold, italicize, whatever you're normally used to in Word, and it'll be displayed very easily. So those are the generic bits of Confluence that I always save, so I always can use as a reference. There is a different space for what I went earlier about ambulatory for each clinic. So you don't have to link these for every single site, but I'm going to say VGH. Sorry, Daniel, which cycle are you going to be assigned to? Do you know? Is it CW or?
No, not yet. For now, I am just with B, working in BGH as doing the shadow part. So she's assigned to BGH and also to some UBC, helping to some UBC. But yeah, so in the
Right.
meetings that I'm being with her is a BGH for now.
Sure. So if I expand the VGH group, there's VGH Wave 1, which was original implementation, Ambulatory Cycle 1, Ambulatory Cycle 2, which is happening now. If I
Yeah.
expand this, expand clinics.
I just still having like some questions. So from where until where is cycle one, cycle two?
Oh,
Yeah.
yeah, there is some
eh,
overlap for a few cycles. But let me just quickly show you this piece first. So this is in the ambulatory space.
Okay.
They should have separate sections for each hospital and then each waiver, each cycle, and it will give you a list of all the clinics. Each
Uh,
clinic that you're working on or that E&B is working on has their own individual page. This page is where the informatics team and us as BAs will drop any documents for related to that clinic. So things like the original questionnaire sent out in pre-design, the PowerPoints used in all of our design sessions. If you have to make any new Visio workflow diagrams, they all get saved on these pages. They also will keep a checklist of different steps. If there are recordings of their design sessions, they also post recordings here with minutes beside it. And then section for Visio documents, if there were any. Forms, these are usually sample forms used at the clinic. And then all documents. So this should include a couple PowerPoint presentations. This works similar to any document on the Confluence page is similar to our SharePoint, where it does keep a version history in the background. So if you ever had to edit something, for example, this one's locked by Eric right now, but if I
okay.
wanted to edit this PowerPoint, I'll hit lock to edit, download my own copy, make my changes, and just drag and drop using the same file name, and we'll add it
Okay.
back in as a version 7. Just make sure
Uh,
you hit unlock when you're done.
okay.
The same thing with our SharePoint or team sites. Just do not add version numbers to your actual file name because version history relies on everything having the exact same name. So when you are working on clinics in the future, it's very important just to search for each page for each one of your assigned clinics and just bookmark it or save it for later, just so you can easily find it. I will
Okay.
say though that every informatics team does things a little differently. I've had clinics where they never filled out this checklist for where they are in the process. So you really have to make sure you attend all those weekly meetings and touch bases to figure out where they are. Sometimes documents are missing from this list at the bottom because they have only sent them by email and they're not on the page yet. So it is also useful to know who you can reach out to if you're looking for something and it's not here.
Okay.
Each page will list who's assigned to it. So you'll have all of your CIS contacts here. The Reg BA contact is here as well. Person from Osween's team is also listed. So when you are assigned a clinic, you have to make sure you are going in here and adding your name. And that's just by going in with the edit button.
Okay.
And this list is also what they use when they're sending out the first batch of invites. So it's very important that as soon as you're assigned, first step, add your name on here. If design meetings have already started, say you traded clinics with somebody or you got assigned halfway through, it's important that you reach out to whoever's sending out those invites, so usually a CIS, and let them know, hey, I've now been reassigned to this clinic. Please forward me your invite list, because they may just be reusing the same invitee list from their first session over and over again.
Okay.
If you don't see your clinic in this list when you're under the ambulatory space, it might be in another space like specialty diagnostics I mentioned. When that happens, it's easiest just to quickly search by the clinic name. So if I search for, say, say Richmond, right, function. So the very first document I get when I search for, say, Richmond Pulmonary Function Clinic is a clinic key. So it's not quite what I want. I wanted the page. And this is not the right clinic page. This is a separate page where someone's just keeping all of their clinic keys. But it brought me to the specialty diagnostics section. So usually you could just expand the list here on the left and find the one you want. Well, this is a very bad example. Let me see if I can find this now. That's why I say it's always useful just to bookmark stuff when you find it, because otherwise you keep searching constantly and it can get turned to a bit of a maze. There it is. So going on the left, I'm under the specialty diagnostics space. And their tree on the left is organized a little differently. It's under gap analysis and design, Richmond. Here's all the Richmond clinics. So this menu on the left, not nearly as nicely organized as the others, but that's all right. If this was a clinic I was working on, I would just immediately bookmark it, so I would not have to do that search over and over again.
Okay, sure.
I think that's pretty much everything for Confluence. Like I said earlier, I will send out links for everything I've showed for the general reference pages, but if there's anything working on or anything that B is currently working on, I'd recommend bookmarking those as well, the clinic specific pages. So while you're shadowing her, you can also see how they update things in real time.
Okay.
Any questions about Confluence before we move on to Jira?
No, I think it's okay.
All right. And has anyone showed you Jira yet? Or is this again going to be new?
This is gonna be new.
Okay. So Jira is the ticketing system for CST for new. It's actually used for so many different things, it's hard to summarize. So Jira was originally rolled out for the CST project. It's what they use for all their tickets. They also create, and there are many different types of tickets. There's tickets for something that is broken. There's tickets to track design decisions if something is non-enterprise. Right now, today, even I have to log a ticket because when I was in cutover, something wasn't working right in scheduling that I have to ask them to fix. That's done through a Jira ticket.
Okay.
So first, let's just go over different projects. So a ticket, this is a sample ticket, one of the first ones I clicked on. You see at the very top, project name and ticket number.
Okay.
Ticket, it will belong to a certain project in Jira. Jira houses, I think, a dozen different projects. We only have access to about 3 of them. The DCV 2.0 project is CST Cerner.
Okay.
Any ticket created under this project will start with the letters CST-ticket number. There are also CEC project tickets. Let's see if I can find one. Let's quickly search for one. There we go. A CEC ticket. CEC is a separate project, so tickets start with CEC, and they have their own ticket number. This is the CST engagement calendar project, so it's really paired together with our first CST project. The CST project is used to log tickets for changes or design decisions. The CEC project is very singular in focus. It's just used to book design sessions.
Okay.
So every CEC ticket represents a different session. So every design session you've been to with B would have a corresponding CEC ticket. And these are used to confirm dates, confirm SMEs and who's attending in advance, things like that.
Okay.
The third project that we have access to is, it's very hard to find tickets for this one. Let me see if I can pull up one more easily. There we go. This one is called the Pro project, which is owned by Providence Healthcare. We see a very small number of these, but Pro is only used by PHC, no other site. So Providence Healthcare, St. Paul's, and MSJ have fully switched over to CST Cerner. The CST project team is really no longer involved. Instead, all of the sustainment work that's happening there is being done by their site informatics team, people that were hired by PHC to do that same type of work that the project team was doing.
Okay.
But in order to separate their sustainment work from the rest of all the CST tickets for upcoming sites, they decided to make their own project within Jira just to keep themselves better organized. So for PHC, that is the Pro project.
Oh,
Because it's only for a single site, there are very few Pro tickets that we ever get tagged on.
got it. So just if you are in PHC, yeah?
Yes, yes. Other health authorities are going to be mirroring this approach. So we are going to see, say, Vancouver Coastal Health specific project in the future. But for now, it's just PHC and the Pro project are the only ones that do things differently for sustainment.
Okay.
But 99% of the time, you are looking at CST and CEC tickets. So that's what we're going to focus on.
Right.
Let me just pull up a random ticket again. All right, so every ticket has project, ticket number, title, and a few different fields. So what ticket type is it? This is an access and learning ticket because this is asking for access for Anchor for
Okay.
CST. You can add different labels to a ticket. This is really just free text. Really type absolutely everything. It will try to match a previous label. And if what you've typed is unique, has never been put on a ticket in the past, it will tell you that this is a new label.
Okay.
But you generally want to try and use an existing label whenever possible, because people will search by labels, and by using a brand new label, people may not see your ticket properly.
Okay.
Anything that's listed as a separate field here, you can search by when you're doing a search for tickets. So things like labels, facility, severity, design team, all searchable fields. Each ticket has a description, which again is free text. You can attach files, just drag and drop. And it's not on this particular ticket, but I will make one later today when I want to have to do this. But you can say that this ticket is linked to another ticket. And that way there'll be a list of related tickets that you can click on to see a related issue to the same topic.
Okay.
And comments that everyone makes relate to each ticket. If this is too long, you will have to click to expand to make sure you're seeing the full comment chain. Ideally, if there are changes in the comments, they should be going back and updating the description. Doesn't always happen though, so make sure you are fully reading comments on each ticket that you need to look at. Going back up to the top, on the right-hand side, it will tell you who's currently assigned to work on the ticket, who first created the ticket, they're the reporter. Votes we do not use. I think it's only used by some working groups, but not anything us BAs have to worry about. And who is currently watching the ticket. If you were to comment on the ticket or you're the one who made it, you are automatically watching it. But you can always click to start watching. Watching a ticket means anytime that there is a change, any change at all in the ticket, someone's changed the ticket status, someone's made a comment, it will send you an email notification, which can get very annoying because sometimes one person making a single edit and attaching a file, maybe changing the status, will trigger 3 or 4 emails coming into you all at once. So I very strongly suggest put in a inbox rule in your Outlook to put these into another folder to keep an eye on. Otherwise, it will flood your inbox to the point where it's unusable.
Okay.
Stop watching. What else? At the very top, there's also ticket status. For each ticket type, the workflow on which statuses it moves through is a little bit different. So access and learning will have a different workflow than a config change ticket where we're asking for build changes to the system. But for each one, you can just click on view workflow and it'll show you this is how this ticket status is supposed to move from one to the other.
Okay.
Well, this lets you know that if it's currently open, you can't immediately move it to training complete. You have to progress it through in progress, pending training, training complete. If you're ever wondering why can't I change the status to say complete or closed, it's because you're missing steps in the workflow. So sometimes when someone is say closing a ticket, you'll see 4 messages because they're moving it through every stage all at once.
Okay.
And that workflow diagram is different for every single ticket type. So let's make sure for each ticket type you're working on, take a peek. The buttons at the top are used to change the status. So training complete, depth provision, which I'm not familiar with, but it is on our diagram, means you're just changing the status to so-and-so.
Okay. That he didn't pass the training in that
Let's
case.
take a look.
No,
So I think there's a long list of classes you guys have to take as new hires, and I think
yeah,
here
yeah.
they're just adding comments for each individual course. Yeah, pending these 3 still.
Okay.
Yeah, so even if he gets all completed, he's not going to get access until this ticket is updated, because this ticket is what they're using as their source of truth. Which also means that if he's completed his training, he can go in and update this himself, saying, hey, I have finished so-and-so. You should see in my Learning Hub history in just a few minutes. Please give me access. So even for yourself, if there's things that you are pending access for, it's helpful just to help move your own tickets along.
Okay.
Right. Running a little low on time, but I want to briefly talk about searching and dashboards. So when you search for a ticket, if I search for it by name, say FPH cutover. So by default, it's always going to do a text search, meaning it's going to search for this either of these 2 substrings anywhere in the ticket itself. It could be in the title, it could be in a comment, it could be in the description.
Okay.
And usually that's okay. If you wanted to limit it to just say the title and nothing else, you would change the field from text to summary. Because instead of calling it title, they call it a summary.
Okay.
You remember I said that you can search by any field in the ticket. So if I wanted to say activation group, forensic, delete all this, I can just search for activation group. And one nice thing about Jira is that the search does try to autocomplete. Equals, not equals, forensic. There we go. And hit search. It quickly filters out everything for you. So anything that is a field, you can search by, which is very, very useful because it lets you really drill down to specific tickets. As you may have seen, it does have other conditional operators, so you can search, you can combine searches. So forensic and the label includes RSTQ. RSTQ. Because here is just searching for every label that's already entered into the system, and it does autocomplete as you type.
Okay.
I don't think we have any forensic activation group tickets with an RSTQ label, for instance. Oh, what else is useful? I think I use status is not equal to closed. Is useful as well if I only want to look at active tickets. Sometimes you don't care about closed tickets. Or you can search by ticket type, which I find really useful. And type equals, I think every time I'm searching by type, I'm always looking for an escalated design decision. Because these type of tickets, EDDs or design decisions, are presented to working groups for approval. This is when a decision is needed for a non-enterprise workflow, or even for things like what are we cutting over? Look, what defaults will we use instead? So EDD tickets tend to be a very useful source of info for localizing or clinic-specific info.
Okay.
So being able to quickly search by ticket type really helps you find relevant tickets. What else you can also use is order by. I think I was always just do order by updated to see my most recently updated tickets. And if you wanted to say search by a ticket that had someone's name in it, for example, here I'm tagged on this ticket. Because they tagged me, I got another email that says you were specifically mentioned on this ticket. So that way I would know that this is something I need to action because someone has tagged my name here specifically. You can search for tickets where you're tagged, but it's important to note anytime you tag someone, it's done by typing the @ symbol and then clicking their name from the list. So you can do a name search. But when you're searching for it, you do not search by name. You're actually searching for the email attached to the name.
Okay.
Which is not intuitive at all. But I'd really recommend just fiddle around with searching. Pay attention to different fields on the ticket and just try searching for it, because the search tool is very full-featured. It just isn't obvious at a glance, because when you type in here, it just does a basic text search, which I use very rarely. If there's a search that you are using very often, you can hit save, and it saves it as a filter. To go up to the top of Jira, where is it? Manage filters. Okay, for it to slowly load, I have a ton.
Yes.
Here's my test filter I just made. So you can always just click on this and it will automatically fill in your saved search for you.
Okay.
So if there's a certain tag that you know all of your tickets are, or you're looking for a group of several tickets and they all happen to share the exact same label, or you've added the same label to each of them, you can just save a search looking for that label. If you want to share your search with somebody else, by default, all of these filters are set to private. Let's click on the wrench icon, edit, and add any logged in user. Hit save. And now that says it's shared with logged in users, I can share this link with anybody else and they'll see the exact same search. So if you are working with other people on the same set of clinics, you can always just share your searches as well. The reason why I have so many that if you see on this list is that you can also use filters to create a dashboard. Let's do personal tracker. So dashboard, I'll also send you these links. When you search for tickets, I said you have to search for someone's name by their email address, right? There is another variable you can search for that says current user, meaning whatever email address this person has logged into Jira with. So using that, I made some filters searching for anything that includes my email, my name. Tickets I'm mentioned in, or tickets that I'm watching, but I'm not currently mentioned in. Both these searches are set to current user. So if I share the link to this dashboard, it works just fine for you as well. You'll see your own tickets, stuff that you are mentioned in. It's also you can sort it by like severity. Dashboards are really just different ways of displaying saved filters. So if my edit option, if I edit this one, this is just a gadget that's pre-built into Jira. It's just saying, I forget the exact name of this gadget. I think it was just this list filter results, something to that effect. And here, just saying, pick one of your saved filters. And that's the results we're going to display. A few edits to columns, but these are very flexible. This I first made just as my own personal way to keep track of tickets because I found all the emails too difficult to keep track of. So I just like looking at the dashboard instead. And then a couple other BAs saw it and they also asked me if they could get copies. So I just changed it to use current user, set my own name, and now it's going to be used by anybody. There's a similar dashboard for the BA team, which lists all of the upcoming CEC sessions for the ambulatory retro scheduling. So we have it all as a nice calendar view. Again, this is just a different type of gadget that's pre-built, looking at a different filter. So if you want to make your own dashboards, very easy to do. But it's all based around filters and saved searches. So I'll recommend get proficient at searching, saving your filters. And then if you want to pull those saved filters into a dashboard, you can just make a new dashboard anytime you want. There's no approval process. You can just go into Jira settings and just hit create new dashboard. Things under manage, create new. Yeah, create new dashboard right there. For how we are notified on Jira tickets, it's also worth mentioning. So we are notified about a Jira ticket either because it has the right label and we're actively searching for that label. Otherwise, people have to tag us by name. So that's why in comments, you often see people getting tagged because they want to bring it to their awareness. This can be a problem. So number one, that's why you want to make sure your name is on those Confluence pages where you're saying, yes, I'm the BA for this clinic, so they know who to tag. But it also means that if you're away on vacation that week and they tag you, no one's going to see it, which does happen sometimes. It's a large pain point. We've asked them, can they tag our shared BA inbox instead? But they said, no, it's not possible. They will not add a generic email to Jira, so it always has to be individuals. So if you know you're going to be away for an upcoming week for vacation, and someone's talking about a ticket they want to log, maybe give them more than one name to tag just in case. That's why people typically tag a few people at a time, just make sure they are getting someone who is currently in office. I think that's about it. So I was looking at time. I know we have a RCQ meeting in just a second. It's essentially it for tickets. To create a brand new Jira ticket, it's create button at the top. So here it's project, which project you want to create it under. Put it under the CST project. Ticket type. So access and learning is if you want access. We never use this one. Config change, it means that I want them to change something in the build. EDDs are for, like we said, design decisions. IMS requests go to the IMS department. At RSAQ, we only use these when we are submitting requests for extracts for cutover from the legacy system. Learning deliverable is I know the UR team uses this more often, but as BAs, I think we've only used this if we want changes made to CSD help. These are not applicable to us. Yeah, so I think majority is just going to be config changes, EDDs, and occasionally IMIS requests we're going to be using. For example, today, I need to make a config change ticket because there's a problem during my cutover yesterday. So I've already typed out my description in advance. So title, so you can see here the field is called summary. So this is just free text, but not do that twice. Trying to rush through this quick before our next meeting. Here we go. Activation group. So this is going to be, just so that people can filter it out nicely, is UBC on here? UBC. Great. Not a required field, so leaving it blank. Programs, we're pretty much always selecting registration or scheduling. This particular ticket is a problem with their schedule appointment book. Oh, do I not have scheduling on here? No. Oh, okay. I'll just pick registration for now. I can change it later after the ticket's done. This is passive build. Pretty much always picking passive build unless it's a temporary build change done for cutover. Category, I want to say change request sustainment. We are not part of the project team, so it's always either going to be a break fix, meaning something's broken, please fix it. We're asking you to change something for, and it's a sustainment request, meaning it's already been set. They're just asking to change after the fact. Actually, this one I actually want to pick break fix because I think it's broken. It's not working as intended. Severity, it's going to default it to medium. Same thing with priority. Design team. This one should have scheduling. There we go. And am I flagging this because I want a new report or changes to report made? No, I am not. I'm not going to put myself as the owner yet because this should go to someone on the scheduling team. It relates to a different ticket, and I made sure to get that ticket number earlier. So it relates to ticket number so-and-so. Labels, I do want to add the same label they put on this clinic, which I did look up in advance. And again, you know what, non-mandatory field, don't think it matters. That should be everything. Great. There we go. And that's all I have to do. If I made a mistake at any point here, just hover over. You can always change those values afterwards. So you don't have to worry about making it perfect right away. It's more important just to log the ticket, get eyes on it. If you put something in incorrectly, it's not a big deal. It can always be tweaked afterwards. It's more of a problem if you put the wrong values and people who need to see it aren't aware yet. I'm also going to tag somebody, the CIS who I spoke to about this yesterday, because I told her I was going to log this ticket. Oops, not do it by email. I have to do at. Run award. Is she not in here? There she is. And I'll quickly add a comment, just so she gets tagged and she sees that it's been made. But I've already spoken to her about this issue yesterday. She's expecting me to tag her. And that's it for a ticket. Because I made the ticket, I'm the reporter. I'm automatically watching it. When there's an update, I'll see it on that dashboard, and I'll just make sure if there's any other comments or activity. I'll keep an eye on it, help push it along if necessary to make sure it gets resolved. Or maybe nothing happened. I still need to know the resolution so I can communicate out to the clerks in this clinic. All right, I think we're about 5 minutes over for our other meeting. I will send you a ton of links afterwards. If there's any questions after this meeting, please just feel free to poke me. I am going to be on site for almost the next 2 weeks straight, so I will have very odd working hours. So it's probably best to email me because I believe I'm working just afternoons for the next week. So you won't see me online during the day. But email, I'll be happy to answer anything I can. All right. Otherwise, I will
Okay.
see you in our RCQ meeting.
Okay. Thank you.
You're welcome.
See
Bye-bye.
you.